Toronto international rounds. Is for me a great pleasure to introduce Dr. Mah, who from Columbus, Ohio, and she has agreed to I think it's kind of thinking in a better lecture to start the academic year than learning how the lesions form and learning about embryology. I never heard her lecture, but I've been told that it's spectacular, so I'm really looking forward to it. So, Mei-Ling, thank you for joining us, and please, just the floor is yours.
Well, thank you very much for inviting me. I think that this is a fun way to start, and I hope that people aren't completely bored by the concept of embryology, so we will try to make this clinical and interesting. So this talk I wrote probably 11 or 12 years ago when I was a fellow in Toronto at Irwin's request. We were sitting in that small conference room right by our office bay, and we were just drawing pictures. And so we were having this conversation and drawing it out. And in true directorship form, I think Irwin then directed me to actually make it into slides. And so we built this talk back then and hasn't changed much, including the drawings from that day. So the objectives of the talk I've shared in terms of the posting, but really I would like to augment an awareness of major anatomic lesions, to heighten an awareness of what else I should be looking for, and then also to provide a common nomenclature. I think that we underestimate how important it is that everybody understand what we're saying, in part because I think when we're communicating and we're trying to describe lesions, these details become important, as we're often interdisciplinary. We're often working with surgeons in close proximity. And so having kind of a common nomenclature makes things clear and it decreases mistakes. So this is not an exhaustive embryology schedule of events. It is not an exhaustive review. I will leave that to your medical school courses. We do allude to a lot of those things here, but there will be no memorization of schedule. So I like to think of congenital heart disease by developmental type. And so to me, there are really three large groups. And if you think about them this way, if you've seen congenital heart disease, then it should make some sense because you've seen all of these lesions. There's persistence of a normal structure. And so a PDA, normal structure, PFO, normal structure, and both of those persist and may or may not result in pathology kind of as you age. Arresto development in a normal stage, I think, is the most interesting group. So at some point in cardiac development, all of us were DILVs, we were DORVs, we had ASDs, VSDs, we were canals, we had Ebstein's, and we were all truncuses at some point. And I think knowing when there is an arrest in a stage of development is really instructive in terms of figuring out what embryology looks like at those stages, because we see real life living examples of these stages. Mistakes in development often also occur, not surprisingly, in tetralogy of flow and detransposition would be our most common kind of mistakes. So all congenital heart disease makes sense if you understand how the heart develops. And so I find it really fun to go from the clinical side back to the embryology side. So this is the timeline of human heart development, and it is exactly the type of thing I'd like to avoid. The only thing that I would mention is that the heart develops at about 3 weeks of gestation, so obviously 1 week after missed period, and then up to 7 weeks. And so it's very early. So this is my slightly simplified timeline of heart development. So you have to form the tube, you have to loop the tube, you divide the tube, you make the valves, and you divide and finish outflows. So it should be very simple. So we talk first about the heart tube and looping. So this is a text diagram of how the heart tube forms. And so it comes together in midline, comes together and then loops. And you'll see that it loops with that cardiac mass going towards the right. Looping to the right is normal, and that's considered a D loop. So this is just a pictorial, it's a depiction kind of in vivo in the actual embryo. So pulled out, this is the heart tube in separate, and this is when you start labeling the different parts of the heart tube. And so this is the aortic sac up high. It's going to give rise to the great arteries, the conotruncus, which is a very important part of embryologic development, the primitive right ventricle, followed by the primitive left ventricle, followed by the atria. And you see here how it loops to the right, and that causes kind of the mass to swing that way. And so you really kind of loop on this fulcrum between the RV and the LV. So when we look at segmental anatomy, so oftentimes when we write our echo reports, we usually give you some designation in terms of this is an STD heart. And so what we're really describing is the segmental anatomy. The biggest mistake I usually see is that the first letter people assume is for atrial sidedness. It's actually abdominal sidedness, which is a surrogate for the atrial sidedness. It is actually not the best surrogate for atrial sidedness. It's actually a bronchial artery branching, but this is by convention what we use. S being normal, I being inversus, and A being ambiguous. The second letter refers to which direction you loop, and we'll talk more about that a little bit later. And the third letter is arterial position. And so L meaning aorta is rightward to the PA, and D being the PA is rightward of the aorta. So a normal segmental set is SDL, and D transpo is an SDD. This requires some practice, but once you're used to putting it in every echo report you write, it's not that hard. Sometimes the hardest thing to figure out, in particular with single ventricles, is which direction the ventricle looped. This is a pathologic designation, and so it was back in the day when imaging wasn't really something they had, and so you were looking at these pathologic specimens, and so the pathologist would literally take their hand and place it in the heart with the thumb in the tricuspid valve and the fingers in the outflow. If this required use of your right hand, it was a D loop, and if it required your left hand, it was an L loop. Now that we have MRI and echo, but easier on MRI, you can really do this kind of in your head by doing the rotation. And so this will help you very much in terms of looping. So how does it know which way to loop? And so you get clues from the body, and so it's a global plan. And people have drawn these very intricate cascades and all of the different factors that go into determining which direction things loop. And so ventral, dorsal, left, and right have already been determined. But if the body is confused about what is left and what is right, the heart gets confused too. So if the heart's confused about which side is which, or interprets the left and right cues differently than the body, then there's a very high likelihood of cardiac defects. And so that's the heterotaxy patient. We'll talk more about isomerism later, but if the body just gets confused and everything that's left is left or everything that's right is left and everything that's left is right, then actually you just get situs inversus totalis, which the most common cardiac structure is normal. So if you get it all confused, but consistently confused, then you're fine. It's when the things kind of fall in between that you get in trouble. So aligning inflows and outflows, I think, is one of the more fun pieces of it. And so this is when you get to see the drawings. And so I always joke with this that Irwin didn't pay me very much as a fellow because I only had a limited number of colors of Sharpie. And so these were all drawn kind of on transparency films because we are that old. And so in coloring it, this is the same, it's a different depiction of the heart tube that I showed you before. So these are the aortic sacs or the outflows. This is your conus tissue, the right ventricle, left ventricle, and atria. So when you start to loop, and this is again the folding right on that RV-LV fulcrum, you end up here. If you were to arrest at this stage of development, you would be a double inlet left and a double outlet right. Because all you've done is successfully looped, the atrial connection to the left ventricle persists because that's the order in which they present in the heart tube. And the outflows are both attributable to the right ventricle here attached to this conus. And so you're a double inlet left, double outlet right. And so we affectionately refer to this in the echo lab as a tube heart. So the next things that happens is that your inflows realign to midline. And so obviously you need to get one of your inflows over the RV and one over the LV. And so that occurs next. If you stop at this stage of development, you are a double outlet right. So now you have two AV valves attributed to two ventricular masses and then two outflows, but both of those are attributed to the RV in attachment to this conal tissue. And so the next step is more interesting, and I'll go into detail about this. The conus on the left side regresses. So you continue to have an infundibular stalk on the right ventricle, but you'll note that the LV has no infundibulum. So the right-sided conus regresses. That regression pulls one of those outflows over the left ventricle, and only then do you kind of complete your realignment to midline. So this is, I'm an echo person, and so I think of things in echo images. And so this is a parasternal long axis. I've taken the liberty of drawing the PA anterior, which you obviously don't see in a normal parasternal long, but just for the purposes of illustration, that red mass is sitting between the aorta and the mitral valve. That is conus. It's residual conus tissue. And so when you see a lack of aortic mitral continuity, you have residual conal tissue. So what happens in terms of the shift to midline, it's not magical. What happens is the left-sided conus regresses. And so it's a double outlet right if you don't regress. if this tissue regresses normally, what happens is the great arteries are then pulled posteriorly. You develop your aortic mitral continuity, and this is a normal heart. So I mention this specifically because this is in contrast to another lesion which often gets confused with double outlet right, which is tetralogy of Fallot. Tetralogy of Fallot has a different embryologic problem, right? We've already said that this is a mistake in development and not an arrest in a stage of development. And so in tetralogy of Fallot, the problem is you have anterior deviation of the conal separation. And so the aorta and PA are divided unequally. So in a newborn, aortic dimensions are about a 5 millimeter aorta, same thing with the pulmonary artery. They're fairly equal, and sometimes actually the PA just a little bit bigger, frankly. But if you divide unequally and you have anterior malalignment, what happens is your PA is small and your aorta is large. Because of that, the ventricular septum doesn't know where to go, so you end up with a VSD. You can end up with the subpulmonary narrowing or infundibular stenosis, and you end up with a big aorta. You'll notice, however, though, that the aortic mitral continuity is maintained. So I think that that's how you can tell the difference between a TET. I will not call a double outlet right unless I see conal tissue and that lack of aortic mitral continuity. This is a double outlet right patient, and you see that echo bright lump here, kind of between the aortic valve and the mitral valve. And so this is an example of conal tissue. So this would be a double outlet right ventricle patient and not a tetralogy. So this is the controversy. So the Society of Thoracic Surgeons have a nomenclature which is the most general. And so they pretty vaguely say that DORV is a type of ventricular arterial connection in which both great arteries arise either entirely or predominantly from the right ventricle. So very vague. Von Prague, who is clearly the Von Pragues, are both a husband and wife couple, were both cardiac pathologists. And they defined it as the presence of conal tissue or lack of great artery mitral continuity, which is what I've presented to you. It addresses the TET with extreme aortic override. This is not DORV because of the aortic mitral continuity. Bob Anderson, who was another very prominent cardiac pathologist, had a 50% rule. They said if the aorta is greater than 50% over the RV, then you are a double outlet right. So I'm biased. My training is that you have to have a conus. And so, you know, I think this kind of makes sense because if you think about your apical 4-chamber view, the aorta in normal hearts is not a purely LV structure. It actually lies over the muscular ventricular septum. When you do that 5-chamber sweep and you sweep anteriorly, it's very clearly kind of lying over ventricular septum, not purely an LV structure. When you have a VSD in that location, I don't know where you draw your 50% line. You can swing it to the right or to the left just based on the angle of your acquisition. So this allows for tetralogy of Fallot patients to be included and counted in DORV cohorts, in particular for outcome studies. And so, but these are two very different diseases. I think that, you know, TET outcomes are better than DORV outcomes. And so when you kind of dilute that data, it's kind of hard to interpret. And so I tend to be a purist. And so I like the lack of aortic mitral continuity definition because it keeps things clean. So we move on to double inlet left. So this is clearly a Fontan patient with 2 inflows into a morphologic LV. And so not hard to tell, but a large Fontan pathway, systemic atria, the 2 AV valves, and here's a nice smooth-walled LV. So from an embryology standpoint, because of how the tube is oriented, double outlet left and double inlet right shouldn't really happen because the atria are connected to the LV and the RV is embryologically attached to the aorta. You really shouldn't be able to be a double outlet left and a double inlet right. But then sometimes it does. And so it's rare though. And so if somebody comes to you with a history and they're described as double outlet left ventricle, you have to kind of question that. So there are only 3 described in the Boston Children's sample for decades. However, the Von Pragues were at Boston Children, and so it has very much to do with this very strict definition. They've reported a total of 102 cases in Boston over decades and decades. The issue is you have to have, your heart has to do too much, not enough. And so both conal, the whole conus has to regress to be a double outlet left. And so the outflow then goes too far and overshoots midline. So you end up looking like a TET with both outflows over the LV. And so it's very strange looking, but it's also kind of hard to do too much. Doing not enough, common. Doing too much is uncommon. So septation. Septation is pretty boring. I took out some of these slides because it's just not that interesting. I will mention in this that if you refer to ASDs embryologically, it does result in some confusion. If you say that the primum septum is fenestrated, that suggests you have a secundum ASD. So embryologically, the primum septum is actually what's missing in a secundum ASD, and so it can get confusing. And so the common nomenclature is to refer to it as a secundum ASD and forget about your embryology learning at all, but know that if someone says areas of fenestration in the primum septum, you really do have to clarify that it's not a primum ASD, it's a secundum ASD. So ventricular septation, also not that interesting, but has more components. And so everything comes together. And, you know, I often tell fellows this, that I think VSD, describing where a VSD is to a surgeon is one of the harder things you'll do in three-dimensional space, because the ventricular septum is just not a flat, smooth structure. It has a rotation. And it's a very hard thing at times to describe. And so there's muscular, outlet, inlet, membranous, paramembranous, septum. It comes together, and this is just a drawing of kind of the different potential locations for VSDs. But I think the important point is it's not a straight structure, not interesting embryologically. So the endocardial cushions, I think we should spend some time on, because obviously this problems with the endocardial cushion development contribute to substantial heart disease. So this is an electron microscopy from Langman's microbiology, or Langman's embryology text of a mouse embryo. I kind of like it because it shows you a canal. So this is a primitive AV valve. I've labeled it for you. A tricuspid valve and mitral valve is what this becomes. But the relationship between the endocardial cushions and the outflows after you've looped are incredibly close in proximity. And so being able to see this single slice really helps you, I think, in your mind know that we're really talking about very close structures. As it applies to AVSD, I like to discuss kind of the size of the mural or lateral leaflet. Different institutions I've been at have referred to this as in a variety of different words. The most common really is lateral leaflet. Mural leaflet is also quite common. Some people will say it's the posterior leaflet because that's what ends up becoming, but this is a very important structure. And so the reason for that is when you divide an AVSD, you septate there. This is the cleft. And so, you know, the tricuspid valve is a normal 3-leaflet valve. And so already at division, you can tell this is a tricuspid valve. It looks like a tricuspid valve. When you look at the mitral valve, this ends up being posterior leaflet. This is the large anterior leaflet, and this is your cleft. And so you'll close your cleft here with 3 sutures I've added in kind of Photoshop. And so the reason the mural leaflet becomes really important is that that dictates the size of your eventual mitral valve orifice. And so sometimes, like we'll mention in newborns in particular, you have 2 very closely spaced papillary muscles. So we'll make a note of that. And the reason for that is what I'm suggesting to you is maybe you shouldn't close that cleft. So if the mitral valve is going to be small after you close the cleft, you're going to end up with mitral stenosis. And so there are adult patients that I've seen, Downs, for example, where they're not going to survive as a single ventricle, that you'll notice that the cleft is wide open. That doesn't mean that those sutures tore. It may mean that if you have closely spaced papillary muscles, that you decided to leave well enough alone and leave the cleft open. And so you can tell that by the spacing of the papillary muscles and the size of the mural leaflet. So this is an echo of an AVSD. You can see this patient also has a secundum atrial defect. Obviously not the picture you would diagnose that in, but there is one in this patient, a large primum and a small VSD. So I used to kind of get really confused about why sometimes AVSDs were also tetralogy of flow. And then I saw this picture and it made way more sense to me, because the cardiac cushions actually extend out to the infundibulum. And so it's not that you really have 2 mistakes, it's still 1 mistake. It's mistakes in those same cells, but that it affects all of it. And so there's an inner curvature, it extends to the conus. And so it's actually, after I saw this, I kind of wondered why we didn't see more TET canals. But the combination of tetralogy of flow and AVSD is actually still 1 mistake. So valves. So Ebstein's anomaly, if I tell you that the AV valve leaflets arise from endocardium, it should totally make sense to you because you've seen Ebstein's. And so if you look at that tricuspid valve, you can completely imagine that that cell line, that apoptosis line that is supposed to happen between the endocardium or on that top layer of endocardium, such that the leaflets can separate from the myocardium and then float up to the annulus ring, it didn't happen. And so it looks partially stuck. And so we talk about laminated tricuspid valves and Ebstein's. And really what we're saying is that endocardium did not separate appropriately and did not kind of come apart from the myocardium such that it could float to the annulus in a normal position. And so when I first gave this talk, Andrew Crean asked me about this specific thing because I said, you know, it's clear to me that tricuspid valve disease, in particular when it looks like Ebstein's, is a myocardial problem because I know the AV valves come from the myocardium. So it should totally make sense that there's this association with LV non-compaction. In the end, you have a heart tube that is a continuous structure, right? The LV and the RV are continuous. And so if the endocardium is abnormal in Ebstein's, then it should potentially also have a higher likelihood of being abnormal in the LV portion of that heart tube as well. And so this observation that non-compaction occurs in Ebstein's is kind of a no-brainer if you understand the embryology of it. So it shouldn't come to a surprise to anybody that LV non-compaction is also a problem of myocardial issues. And so Andrew Crean asked me if I had ever seen a mitral valve, an Ebstein-looking mitral valve, and I hadn't at the time. And then I went to practice and I had two patients, actually a mother and a son, who had this Ebstenoid valve. And then I took a look at the LV and I was like, well, they also have non-compaction. Again, not a surprise, but then look at the mitral valve. So the mitral valve, you know, the family members, they look like they had identical echoes. I don't even remember which person this was, but it's the mitral valve has also had trouble delaminating. And so this was the first person I had seen, and so I immediately went to my slide deck and added it for the purposes of this talk specifically. So outflows. Check my time. All right. So conal septal rotation is a complex thing. I will just say that the important things for you to know are it divides pretty equally and then rotates. And obviously this is a more elegant picture than I am capable of. If you have an undivided conotruncus, you end up being a truncus. So aorta and PA never divide, and so you end up with one big great artery that comes off. If you have an anterior deviation of your conal cushions, then you have a narrowing of the outflow to the PA and you are a tetralogy of Fallot. If you posteriorly malalign that division, you end up being a posterior malaligned VSD with aortic stenosis. And so this, we don't have a fancy name for this, somebody should name it, but you don't see it as often as tetralogy, but for sure you'll see these posterior malaligned VSDs with aortic stenosis and often cohortation actually, fairly, not uncommonly. And then under rotation of the cushions results in transposition of the great arteries. Sometimes this is associated with malalignment as well, specifically pulmonary stenosis is the most common, but under rotation gives you transposition. So this is my less elegant drawing. And so again, we've taken this peristernal long and we've put it on its end just for the purposes of illustration. And so normal is that you divide 50-50 and you rotate. Tetralogy, you're going to deviate anteriorly. Your PA will be small, but you still rotate. Transposition, you can divide sometimes equally, sometimes unequally, but no rotation. And truncus is no division at all. Pretty simple. So echo image of tetralogy of flow, you can see that the aorta is large here. So this is the septum that's come down, and there's anterior deviation of the septum, result in infundibular stenosis and a small PA. Transposition, obviously an atrial level switch patient with two parallel great arteries that are pretty equally divided in this patient. I will just briefly mention that the truncal valve is usually tricuspid, which I find interesting and I've never been able to reconcile. There's got to be some different kind of embryologic basis for that valve, but it's most often tricuspid. I have not seen a 6 leaflet one, but I have seen a pentacuspid one, which is pretty rare. So the neural crest. So in pediatric cardiology, the neural crest is kind of something that's pretty, we don't really have to think about it that much, but it occurred to me that people, when I was there, were trying to memorize all of the things associated with abnormalities of the neural crest. And so this is the 22q11 deletion syndrome. So the neural crest cells actually form on your spine, so the dorsal neural tube, and then they migrate anteriorly. They pass through the paraaortic arches, and I'll show you, we'll go into the arch more specifically in a little bit, but they influence the patterning of the arch. They also then continue to migrate anteriorly and can affect the growth and development of the conotruncus and the AV cushions. They also affect the parathyroid and thyroid glands. And so the way I think of this is something I'm sure I lifted offline somewhere, and I put a little happy face and a thyroid in there. And so this is where the neural crest sits. And so if you just think about that's where the neural crest sits, and you see these cells kind of, coming down, cleft lip and palate, common, parathyroid, thyroid disease, common, and then obviously the heart disease that we've spoken about. So aortic arches. This is something that I end up drawing kind of over and over again. Clinically, probably once a month, I'll draw this for the fellows because if we have a patient coming in with something, I think it's a good thing to practice drawing, and because it's clinically important. So the fate of the aortic arches is complicated. For the peds cardiology fellows that are on here, this is something you have to memorize for your boards, but we won't go over the specifics of that in this talk. So this is a nicer schematic drawing of the periaortic arches and then your eventual outcome. So I am a simple person, and so this is where I land in terms of what that should look like. So I had a mentor in Michigan, Dennis Crowley, who recently retired, who drew this arch for us, and so I refer to this as the Crowley arch. And so I attribute all of this to him. So this is a double aortic arch. So everybody at some point in their development was a double aortic arch. Everybody actually, so that obviously constitutes a vascular ring if you stay in this form. Everybody actually divides their arch once. So everybody interrupts once. And so we refer to interrupted aortic arch as a pathologic problem, but really everybody divides at least once, or if they don't, they're a double aortic arch. So normal division happens there. So what happens is, so this is a left arch, the right arch becomes atretic, you divide there, and this is what you end up with. So then if you label your structures, the structures don't change in terms of the arteries are the arteries that are coming kind of from the head and arms. And so the right arch becomes your innominate artery, which gives rise to your right subclavian, right carotid, and left subclavian in that order. It's why when we do our sidedness sweeps, you start in a coronal at the suprasternal notch and you sweep back and you look for the first branch of the aorta, which direction does it go, and then you follow it to prove that it bifurcates. And if you can show that, then you know that the arch then goes in the contralateral direction. So if I sweep kind of in the suprasternal notch and go back and I find the innominate headed to the right and I can make it divide into a subclavian and a carotid, then I know I have now proven to you that I have a left arch purely on the basis of that one sweep. And it's because this is how it happens. So we start talking about, and then the ductus I'll mention is a left-sided structure because that becomes important later. Juxtaductal cohorts are generally almost always attributed to left-sided arches because that's where your ductus is. And so it's pretty rare to have a right arch with a cohortation. I have seen it, but it's pretty rare. So let's start with that double arch again. So what happens if you divide there? So that regresses. Then now you're left with a right arch with mirror image branching. So you would do that same sweep that I described to you, and instead you see the first artery going off to the left and dividing. By definition, you have a right arch. So where is the ductus in a right arch? So you see a patient with a right arch and you want to prove that there's not a ductus. You see cyanosis and clubbing in the feet, but not the hands. And so you're very confused and you're, like all of this seems strange. The patient acts like a ductus. And so you're looking at all of this and you're wanting to find it and you do your sweep, you should find it coming off the base of the innominate because it stays where it's supposed to be. It's a left-sided structure. Sorry about that. It's a left-sided structure. And so it should still stay where it always was, which is off of the base of the innominate or at the undersurface of the primitive left arch, which has become atretic. So if we start with our double outlet, or the double arch again, so if you divide here, so you've just made the mistake, instead of coming over to divide in the normal location, kind of past what will become the right subclavian, instead you've moved over one. So what is this? So if you divide there instead, you are now a left arch with an aberrant right subclavian. Probably because of typos, and we're going really fast, I have seen echo reports that say left arch, aberrant left subclavian. Not possible. So if you see something like that, then you know that it's wrong, because this is how it happens. And so you can't be a left arch and an aberrant left subclavian. It has to be the right. And so it happens because instead of dividing beyond the right subclavian, you've just come between the right subclavian and the right carotid. So because the ductus is a left-sided structure, that's not a vascular ring, because your problem is off to the right. However, if you divide here, you are now a right arch with an aberrant left subclavian. Your ductus is still a left-sided structure, and that does constitute a vascular ring. I had to put this in because there was no way I could draw that. And so you can see that here's your right arch coming over the RPA. In this picture, it's harder to tell, but it's a kind of a more of an anterior posterior arch. So you've got this, and instead of that first branch bifurcating, it's why it's so important to follow that and make sure it bifurcates, because if it does not bifurcate, then you have to look for the aberrant left subclavian coming off the descending aorta. Because the ductus is a left-sided structure, it's going to come off of this diverticulum here, attached to PA, and cause you to have a vascular ring. So now let's go to the pathologic. And so this is when you interrupt a second time, and that causes you to have interruption. So if we start with a left arch normal branching, where the first vessel goes off to the right and bifurcates, if you interrupt a second time, now you have a pathologic interruption. So the way you can remember how they're named is a type C interruption happens between the carotids. And so once you know that C is for carotids and it interrupts between the two carotids, then you essentially come around the arch. That's a B, and that's an A. So when you think about patients that you're seeing in clinic, there are a couple of things to remember. So if you don't see the LPA on your echo, and you think that this is an absent LPA, where would you try to find it? Probably off the ductus. You can end up with LPA cohorts. It's a left-sided structure. In each of the aortic arch configurations, so when we do this in person, I will sometimes throw up kind of different aortic arch configurations. In which limbs do you follow a clinical blood pressure gradient? Sometimes it's as easy as, oh, well, you just do right arm and left arm. And then you're not dealing with that miserable thigh cuff and your pen Doppler, trying to find Dopplers in the lower extremity to get a lower extremity blood pressure. You could just go arm to arm. That's a beautiful day when you realize that really the gradient is arm to arm and you don't have to deal with the lower extremity blood pressure so much. It's also important, like say you have a coarctation, but they had an aberrant right subclavian. Well, now the arm to leg becomes way more difficult, right? Left subclavian and right subclavian may very well come off downstream of your coarctation. So now you don't have a clinical blood pressure gradient to follow. I think the biggest mistake would be to say, gosh, I see this gradient on the echo, but I don't get a clinical blood pressure gradient, so we must be fine here. That's not always the case based on your aortic arch configuration. So this becomes a very important thing to mention. While it's always like the last line on your echo right before no pericardial effusion, it's still something that's very clinically important, specifically in certain patients. So the veins, I think that the veins are super complex. I kind of fly through this pretty quickly. Well, the whole talk goes pretty quickly, but systemic veins are complex. And it's hard kind of in three-dimensional space to picture all of them. They really start out as two veins. They're two posterior non-fused ends of the heart tube that become the sinus venosus, and they sit behind the common atria. Into the sinus venosus, so into those atria, drain three sets of paired veins: the anterior and posterior cardinal veins, the vitelline veins, and the umbilical veins. So the umbilical vein obviously is the placental, vitelline is GI liver veins. So the anterior posterior cardinal veins confused me very much, but then I realized, oh wait, there are two pairs of veins and one's anterior, one's posterior in the body. It's just when you look at them pictorially, you're usually looking at it kind of in a coronal. And so you're really looking at it straight on. So the anterior posterior thing never made sense to me, but it does if you think about it in relationship to the whole body. So now I'm going to switch to that coronal view where the anterior posterior isn't so obvious. You have anterior and posterior kind of come together, if you can imagine it, and this is why it becomes hard, because they buckle in the middle, and so they come together, and in this structure you really can't tell, but you know that the SVC is anterior to the IVC, because when you do that bicaval view, the SVC is always a little bit in front of the IVC, and so, but they come together to form this structure. So the anterior cardinal veins become the SVC. Sometimes the one on the left usually regresses because that's an LSVC, but sometimes it doesn't. The left anterior horn is the buckle of that anterior cardinal vein that buckles into the left atrium, and that buckling persists, and that becomes your coronary sinus. The right-sided one regresses, but that left anterior horn is what gives rise to the coronary sinus. So worse than that, so here are the placental or the umbilical and vitelline veins. And so you have, they're paired, and so you have right-sided ones and left-sided ones. We care very little about any of them other than, let's see, other than those two. So the right-sided vitelline and umbilical. So the umbilical is the ductus venosus. We will use that to cannulate the RA in newborns. Persist for a little while anyway. And the vitelline on the right is your IVC. So if we label stuff, so that's what that looks like. So the important thing to know is that the IVC comes from a different embryologic structure to the infrahepatic portion of your venous drainage. And that is important. So that's the supracardinal vein, subcardinal. And so what happens is, if you are an interrupted IVC, it never totally made sense to me why you would just kind of lose that part of the railroad tracks, but it's because it comes from a different embryologic structure. So if that regresses, which you kind of can see, because if the left side regresses, there's some signal obviously that causes regression of these vessels. And so if you regress that segment, your supracardinal takes over because that comes from a different embryologic structure. And you pop off to the azygos because it gives rise to the azygos that then drains to the SVC. And so this is the interrupted IVC with azygos continuation. Okay, so that's all I'll say about systemic veins because they're kind of painful. Pulmonary veins, I think, are also important because of TAPVR. So the pulmonary veins arise from pulmonary buds. They're actually not cardiac structures. And so the pulmonary bulbs start peripherally, kind of in the pulmonary buds, and then come and glom on to the back of the left atrium. And so here they are. There's your pulmonary vein bulb, presumably with 4 pulmonary veins attached to it. It comes on and it gloms onto the back of the left atrium, and it gives you kind of pulmonary venous drainage to the left atrium. So I've marked your left atrial appendage and your mitral valve there because there are 2 pathologic entities that you will be asked to separate. So this is cor triatriatum. And so the way cor triatriatum develops is that pulmonary vein bulb attaches to the left atrium, but subtotally regresses that membrane between the 2. You obviously have to break down the wall of the primitive left atrium and the wall of those pulmonary vein buds to connect, to result in a smooth transition. Oftentimes people will ask you to separate a cor triatriatum from a supramitral ring by the location of the left atrial appendage. If you know that the pulmonary vein buds are non-cardiac structures, then you should know that cor triatriatum, that membrane will be above the left atrial appendage, whereas a supramitral ring is below the left atrial appendage. And I know it seems obvious in the picture I'm drawing. Sometimes it is not that obvious what's what. And so kind of making a separation between those 2 things is important. And you will remember where that left atrial appendage goes if you just remember that the pulmonary vein bulb is a separate structure that's non-cardiac. So let me see how much time we have. So 8:44. So heterotaxy is complex, and you could give an entire lecture just on heterotaxy. I usually will tell you that isomerism, heterotaxy, the next sentence out of your mouth should be, it's like in DORV where the next sentence is where's the VSD. The next sentence after you say this is a heterotaxy patient is whether or not they have a spleen. And the reason for that is it really gives you a good indication as to what you should be looking for. The best marker for whether you have a spleen or you don't is whether your IVC is interrupted. So if you're doing your echo and you're like, this is going to be a heterotaxy and I'm going to spend the next 4 hours of my life scanning this kid, then an interrupted IVC means you're going to have two left sides. The IVC is a right-sided structure. So if it is missing, then that's a fairly good indication that your heart is seeing two left sides and not two right sides. So if you have two left sides, you're going to have polysplenia. If your IVC is intact, then your body probably is seeing two right sides, which means you're not going to have a spleen because a spleen is a left-sided structure. The reason that's important is it's the best kind of predictor. If you look at all of these different types of defects, it's the best predictor of what you're expecting to see. So if you see polysplenia, your veins, your pulmonary veins, probably going to be normal. So you're not going to spend the next 4 hours looking for veins. However, your venous structures and the looping of the ventricles may be a bit of a problem. And so, obviously they're both riddled with issues. But starting out with, is this a polysplenic heterotaxy or an asplenic heterotaxy, will help guide you in terms of what do you expect to see. So an oversimplification of isomerism is really duplication of that side. And so this structure, the A is normal, right? And so you end up with three lobes of the right lung and then 2 lobes of left lung, the heart's off to the left. You can see the bronchial branching here. It looks different. It's a non-symmetric branching, liver on the right, stomach on the left, and obviously spleen on the left. If you're 2 right sides, look at these bronchial arteries, right? They look very symmetric and they look acutely angled as you would see in a right side. And so then you go to the left atrial isomerism, so look at the bronchial branching, and then situs inversus, where you have the 2 sides, it's just on the wrong side. So in clinical practice, this is a normal chest x-ray, and so it's kind of hard to see. This one's actually not that bad, but when I invert it, and then obviously give you a little bit of help with the drawing over the top of the outlines for the purposes of the talk anyway, you can see that, the 2 sides are asymmetric. You can see stomach bubble on the left and a liver on the right. So this person has lots of issues. And so the important thing is, so when you invert it and you trace out the bronchial arteries, you'll notice that they have a non-acute angle and they're symmetric. You'll also notice that the stomach bubble is somewhere kind of in the middle. And so if I see bronchial branching that looks like this, those are 2 left bronchi. Then you're going to be looking for systemic venous abnormalities. You're going to expect polysplenia. You're going to expect an interrupted IVC. So this is interruption of the IVC. Oftentimes people get, I add this here because oftentimes people will get fooled by a dilated hepatic vein. You will often see a dilated azygos actually posteriorly along the aorta, but you really have to show an IVC kind of in the posterior part of the hepatic, and purists will actually make you show the IVC leave the capsule of the liver inferiorly. That's kind of hard to do, but really this is a dilated hepatic and not an IVC. So this is someone, and actually this projection is better, and even before I invert it, but you can see that there's 2 right-sided bronchi here. See how acute those angles are and how very symmetric they are? And so if you see that, then you're going to expect this is going to be 2 right sides. So my IVC should be fine. I won't have any spleens, but I will have an IVC, and it will often have bilateral SVCs. The veins are also going to be, this is the patient you're going to have to hunt for veins on, because the veins won't know where to go because it's looking for a left heart signal and all it sees is right heart. So I know that that was heterotaxy super fast, but I try to get this in under an hour. So finishing touches is fairly brief, but I think important. flow is really important. And so while we've covered kind of the structural defects that can happen, you're very reliant on flow. So what I showed you in the first slide is that the heart has developed by 7 weeks of gestation. The growth of each chamber of the heart is then dependent on blood flow. So in practice, big fetal VSDs are associated with arch hypoplasia, because if you have 2 routes of egress from your LV, one across the VSD and one antegrade, you decrease the flow across the antegrade flow. And sometimes if you don't flow there, it's going to be small. And so the association with VSD and coarctation, or hypoplasia of the arch, is very common and known. Conversely, if you have complete heart block and your stroke volume is super high as a fetus, you always have a big aorta. So babies that are born with complete heart block always have large aortas, because you just have an increased flow kind of at the time of cardiac development. The same thing applies with valvular stenosis. So if you have aortic or pulmonary valve stenosis, what happens is you get ventricular hypertrophy. So it's not that uncommon that early in fetal life, you'll see something and you'll think it's aortic stenosis as a fetus. And then as you follow up that patient, it clearly is going to become a hypoplast because the LV just doesn't grow while the rest of the heart does. Secondarily, that causes high filling pressures, further limiting the flow, decreasing the chamber growth, and you end up with a small and hypertrophic ventricle. So it's kind of a silly diagram, but really you have everything you're going to have as you've put it together by 2 months, and then what happens is flow results in growth over the full gestation. So again, aortic stenosis is going to limit the flow, and you'll see progression sometimes into a hypoplastic left. So in therapeutic applications, there has been a huge push in a variety of lesions, most often kind of an aortic stenosis and progression to hypoplastic left in fetal life. And so fetal intervention has been really interesting. You know, going across and ballooning a fetal aortic valve such to allow for improved kind of LV growth is clearly something that utilizes the idea of flow and growth. So the data on this haven't been great. You know, they've also done this in terms of intact atrial septum in hypoplastic left heart disease, as well as, you know, the aortic stenosis patient with, you know, it's better than nothing, but it's still kind of a work in progress. So in summary, understanding how the heart develops helps us understand how congenital heart defects happen. Conversely, if you understand congenital heart defects, you can also understand heart development. And that backwards loop is really what this talk is aimed at targeting. Arrest in cardiac development can lead to defects. So everybody at one point was a double inlet left, everybody was a double outlet right, everybody had an AV septal defect, everybody was a truncus, everybody was an Epstein's, and everybody had ASDs and VSDs in fetal life. Abnormalities of development can occur in very predictable ways. And so that's the transpo, TET, and aortic arch anomalies. And then finally, alterations in normal blood flow through the fetal heart can result in a very predictable postnatal phenotype of abnormal growth. So I realize that all went really fast. And so if there are questions or anything about anything that I've said, I do not claim to be a cardiac embryologist. This is just something that I've put together being a clinician. So if anybody has questions, I'm happy to take them at this time.
So thank you very much for excellent talk, and it was really didactic, and I really enjoyed it. We have a question from Poland. So if you have a patient with an isolated persistent left SVC, would you expect this abnormality? Can you mute your microphones, please?
Yes.
So let me just, if you have a patient with an isolated left SVC, would you expect this abnormality to be really isolated, or should you look for another defects?
It is most commonly a normal defect. Sometimes you can tell that they're going to have an LSVC. You know, the first thing is the dilated coronary sinus. The second thing is absence of the innominate vein. And so when you do that coronal, you usually see the innominate vein crossing over the top of the transverse arch. Typically, if the LSVC goes to the coronary sinus, that is normal. We see that a lot as just, we actually refer to it as a normal variant. It becomes an issue when someone wants to put a pacemaker in. We've seen that a few times, like that's a problem, or a central line. The only other time it's really pathologic is if you're a purist and you're not sure, you can't show that it drains into the coronary sinus, then you're really obligated to bubble the left arm. So you do a saline contrast in the left arm, because if it drains to the left atrium, then your patient should be cyanosed. that is pathologic. So the one entity I would look for is that instead of going to the coronary sinus, it goes to the roof of the left atrium, and that it causes some degree of cyanosis. Those actually do get either subtotally ligated if they don't have an innominate vein, or completely ligated if they do.
So Dr. Thom in the chat said, well, what a beautiful talk, thank you. With an interrupted IVC, what determines whether there is an azygos or hemiazygos continuation?
Yeah, it can be either. It's usually to the right, but if you have an LSVC, you can go to the left. Probably it's if I were to guess, because I'm not 100% sure, but if I were to guess, it's going to be on which SVC you have. So the ones that I've seen that go off to the left are patients who are heterotaxis that have LSVCs only. But generally it's going to go to the right.
So if anybody has any questions, just either just type it on the chat or unmute your microphones and you can ask the questions. So I have a question. So if you have a patient with unroofed coronary sinus and you have a persistent left SVC, does the persistent left SVC drain on the top of the left atrium or drains into the remnant of what would be the coronary sinus?
Yeah, that's really hard to tell. Functionally they behave the same, and you kind of treat it the same. I would say that the one difference is whether you call it an unroofed coronary sinus and whether you accept some degree of desaturation even after you do your ligation. I would say, I guess that's the difference, because you're really talking about fairly small real estate. You're talking about, does it drop kind of posteriorly or a little bit anteriorly? I mean, and so you're really talking about a very small move. Sometimes you can still see an intact coronary sinus. So I think if you have an intact coronary sinus and you have an LSVC, then you can confidently say, oh, well, it went to the roof of the left atrium. Otherwise, I don't know that you could tell.
Okay. So there's another question here that in presence of a common arterial trunk, is any way of predicting whether or not you're going to have a persistent left SVC?
In a common arterial trunk?
Yeah. In a common arterial trunk, can you predict if the patient will have a persistent left SVC?
I don't think so, because I think of those as two very different developmental things. I guess I wouldn't necessarily think those are related. Absence or persistence of a ductus, is that what?
Yeah, I think that probably is what that.
Oh.
They wrote the SVC, but I wonder what that would be the ductus.
Oh, yeah. So usually there's no ductus, and if there is a ductus, you're worried about interrupted arch. If those babies have ductuses, well, there are really two scenarios where they have ductuses. One, that you've missed the diagnosis as a fetus and you actually have a TEP pulmonary atresia MAPCA with a ductus feeding contiguous PAs, because that's very hard to tell. So if you think about TEP pulmonary atresia and truncus, right, those can be difficult to distinguish. So if you have a ductus and you're thinking this patient is a truncus, then you should really consider TEP pulmonary atresia and not truncus, or you should consider that the ductus feeds the descending aorta and that you also have an interrupted aortic arch.
That was my question, the differentiate between TEP pulmonary atresia and truncus.
Yes. Yes, and sometimes what you have to do is they get very blue when the ductus closes. That's how almost clinically what happens is the ductus, you have to say, okay, well, there's a ductus and it comes from the undersurface of the arch or it comes from the innominate and it feeds structures that you think are pulmonary arteries, then that's TEP pulmonary atresia. The proof of that is if you don't start the patient on prostans, because you would not put a truncus on prostans, right? A truncus is going to overcirculate. They've got two hoses coming off their ascending aorta. So if you don't start prostans and the baby turns blue, turn on some prostans because that's a TEP pulmonary atresia. So, but you're really looking for PAs that are contiguous and come off a structure that looks like a ductus. In part, it's just what does it look like? But it's clinically, they look like very different patients.
Any other questions?
Well, yes, I do have a question once again. I want to clarify my question about this isolated persistent left superior vena cava. I was asking because we have a patient who has only the persistent superior vena cava, so no normal SVC on the right side. And there was a problematic implantation of ICD, and he ended up in this with the surface ICD. But my question was, if we don't have this superior vena cava on the right side, so it's only isolated persistent LVC, should we search for any other defects, or is it common just to have this isolated SVC?
That can be common. I would say that the most likely association is an ASD.
Okay.
But usually that's all you've got.
Okay, perfect. Thank you.
I just want to make a comment, Mei-Ling. I think I really enjoy your talk every time, and I learn a lot every time. And really, I like this developmental approach to explain the congenital heart defect. That was the end of the product. And actually, what you said, it's actually all of us went through the journey of this difficult congenital heart defect, but at the final end, the product was okay. But if something's going wrong, we can end up with any type of congenital heart defect, as you explained to us. So thank you very much, Mei-Ling. It's very good. Please don't forget to complete the survey at the end. You can earn CMEs.
Okay, so if there is no more questions, it's already 9 o'clock, and I want to thank you again for accepting the invitation for the excellent talk. I really enjoy it, and thank you all for joining us, and we will be back next week. Have a good day, good afternoon, a good night, wherever you are in the world. And thank you, Mei-Ling, again. Thank you.
You're
Bye.
welcome.
Bye.
Bye.
Thank you.